Good morning. For those of you who don't know me, I'm Jeremy Grimshaw. I'm a senior scientist at the Ottawa Hospital Research Institute in Canada. For the last 35 years, I've been an implementation researcher and also very heavily involved in the Cochrane and Campbell collaboration over many years. It's a great pleasure to be here. Normally, I arrange to leave Canada when it is incredibly cold and white there and go somewhere where it is incredibly warm and sunny. I think I got it wrong this time, but it's a real pleasure to be back in South Africa and in Cape Town. I have the interesting position of introducing someone who, as a foreigner, I'm kind of really interested in the very detailed bio and learning about him. My guess is he doesn't need much introduction in this audience. And he did sort of say keep it short, so I'm going to keep it short, apart from the fact, just to clarify, it was very interesting to read the full bio and to really understand his journey. So if there's anyone in the room who doesn't know, Professor Moshabela is a Vice Chancellor and Principal of the University of Cape Town. He's also the chairperson of the governing board of the National Research Foundation, and until recently he was a Deputy Vice Chancellor of Research and Innovation at the University of KwaZulu-Natal. He has many other sort of roles and responsibilities at a senior level in South Africa, but also has his own research program and is clearly a man after my heart because his research is focused on implementation science of health innovations. And it sounds like he's a perfect person to kick off this symposium. So I'm going to ask him to come to the stage and we'll see how we get on. He's going to keep his comments relatively brief. I've told him not to be too worried about that, but really to try and encourage conversation in the audience. So as he's talking, start thinking about, well, what are the kind of pressing comments or questions that you'd like to say both to Mosa, but also to the audience at home, across the meeting. So Mosa.
Thank you so much, Jeremy. And also just want to extend my gratitude to Tamara and team for the invitation. I have to say that I didn't realize how persuasive Tamara is. As you can imagine, because I started my job with UCT on the 1st of August, there was no slot in the calendar. How she created, I've got no idea. I need some of those skills myself. Professor Ntobeko Ntusi, the SAMRC President and CEO, my greetings to you and to the whole MRC. Nick Crisp, my greetings to you and the National Department of Health. Rino, greetings to you. There is someone towards the back there, Helen Schneider. Greetings to you. Helen was my PhD supervisor. When I saw her, I nearly ran towards her to get a hand. Liesel, greetings to you as well, again, and to the MRC. There's a number of colleagues that I've seen here. I've seen Kobas as well from ARI as well. All structures and institutions that are playing a key role in this country. I'm sure there's more people and institutions that are playing a role in defining the health system in this country. And I just want to thank you for being part of this. And I hope that indeed, President, that this is not the last conversation that we're going to have. Over the years, we've had a number of these conversations, dialogues at national level, at provincial level, to try and understand this. It is a complex matter that we are discussing, but at the same time, a very important one for the country. Just like in many other spaces, we are finding that we are at a very critical time in our country And it's going to be up to us how we're going to move forward. I was giving a talk at Stellenbosch University last night, and as you can imagine, they're supposed to be rivals with us as UCT. But my message to them was that rivalry takes us nowhere. There are more important issues in this country to discuss than to be engaging with the Ivy League rivalry. And essentially, I was saying to them that let's work together to address the bigger, grander challenges, the polycrisis that we have in this country together. And I'm going to extend that same message to all of you. Egos don't take us anywhere. I want to send a message to the MRC today, and probably really driven by your unit, Tamara, together with your network of colleagues and partners nationally, that we need a comprehensive research plan for the NHI. Comprehensive. It needs to be explicit. It needs to be visible. And we need a Gantt chart on it to see how far we're doing. And a large part of the reason for it is the fact that there is a lot of unknowns on this issue. And a lot of people need guidance on how we move forward, and we can't just do it based on our instinct. We can't provide guidance just based on our instinct. We need the evidence to do it. And at the moment, I am not aware, and I should be, I am not aware of anyone or any entity that has taken the leadership to lead the research agenda for the NHI. I'm not aware. I'm aware that there's a lot of individuals that are taking initiative, but I'm talking about institutional leadership because that comes with accountability. It's hard as a nation to hold account individuals, but entities can be held accountable, and we need that leadership. It's a big responsibility. It comes with a lot of accountability, but at the same time, it comes and it brings a lot of authority. And I cannot think of a better institution to lead this at the moment than the SAMRC. You can tell me if I'm wrong. I'm not challenging you, I'm just sharing an honest opinion. You need to be open and loud about it, that agenda. You can consult with various people. I'm sure a lot of people would be willing, many people in different universities would be willing to provide support. You would be amazed at the amount of goodwill from a lot of researchers in many universities, relatively small research units and so forth, but a lot of goodwill. They are also looking for a way to find the answers, and they need leadership. Nick, what we need from you is money. Ayakoma. Nick likes to tell this story where he says, yeah, what do you want? What else do you want? What else? Okay, now here's the list. Which one do I cancel? Which one do I remove? Making the point that the budget is strained. But we have to be creative. Nick, you need these thinkers to assist you in answering many of the questions. I know that you've done your part in terms of leading from a government perspective, but this is not something that you're going to be able to do alone. This is perhaps the most important reform in this country in our recent times. We can't get it wrong. And at the moment, you know, it is taking. It's at any point it can fall over the cliff because we know of the power of the forces that are opposing it. So the losers at the end are going to be people that we advocate for, people in communities, in households, that many of us know so well, that we engage with when we do our research. They are the ones that are going to be losers at the end. Those of us who get to sit in the boardrooms, who will remain comfortable with the securities that we have. So we've got to make sure that whatever barrier we have, even if it's a financial one, we overcome it in order to make sure that that you can rally your troops. When we talk of research, you will all know that one of the first things we have to do is to define concepts. At the moment, the language for me is not clear, the language that we are using. It's not consistent. I'm not sure that when we're talking about NHI, we all understand it the same way. When we're talking about UHC or universal health access, I'm not sure that we have the same or the common understanding of what we are talking about. We pick up these concepts because they are used and we run with them. I remember in the early days of these discussions around NHI, I was like, so what is NHI? And they're like, oh no, it's UHC. And I think it's still happening. Those who are close, they've also redefined it for themselves in terms of what it means. This is dangerous. This is where miscommunication and confusion starts. During COVID, I spent a lot of time trying to explain concepts and define concepts, and one of my dear colleagues accused me of, someone in the public accused me of being a professor of semantics. And a dear colleague of mine said, yeah, it's true. Then I reminded them that what do we do when we do research? We start by defining concepts. There's a reason for it. The language is very important. So let's not take the language for granted. Let's ask the question, what do you mean? Describe it, define it. If we don't do that, then we are going to lose each other in the process. And we're going to speak past each other. I say this because I was part of a Lancet commission looking at the synergy between UHC, health promotion, or as some call it, healthy populations, and this whole thing around security, health security. We had a 2-day meeting. The first day of the meeting, a few years ago, it's published now, but the first day of the meeting when we started that, we spent it debating the meaning of concepts. Debating. You have no idea how many definitions there are of health security. Health security. And this is important because also when we talk of UHC, because these concepts are promoted by international agencies and groups globally, they are in our faces, a lot of funding come behind them. We take them on, we run with them. Because many of us will go where the funding is, right? Right? So in the process, we drop some that are not as sexy. Imagine the benefit that comes from health promotion. Imagine that. The cumulative benefit of health promotion. But how come we talk so much of UHC and rarely ever talk about health promotion? And the WHO suffered the same problem because in the WHO team, they had the same tension. The three major groups in the WHO fighting for resources. One's driving UHC, the other one is driving health security, the other one is driving health promotion. Do you know which one won? Followed by? That's it. Who lost? This is the problem. The whole thing around the triple billion, it's around that. And that's why the current SG was trying to bring these groups together to say that they all matter. And for me, it makes me realize that actually sometimes you think that you're pushing your own priority and agenda, but actually these are priorities of others. So what does UHC actually mean? I think that we have to interrogate this because coverage is one thing, and I have to say that South Africa in general has done well. Ever since the policies that were introduced since post-1994, we've come a long way, and we have to give credit where it's due. Yes, there are still problems. When I embarked on my PhD, as I said, Helen Schneider was a supervisor. I thought that I was going to study the introduction of the antiretroviral treatment program, and I was interested in clinical outcomes when you decentralize services. What I found was a problem that has to do with catastrophic health expenditure. You can imagine my confusion as a doctor. I mean, that's not really what I was trained to think about. The cost that people incur when they engage with healthcare, travel cost, meal cost, all sorts of costs. That's what I found. And the trade-offs that are involved when we decentralize patients from hospitals to the clinics near to them, they got their ART, but were no longer able to get the comprehensive care that they got at the hospital because now they're at the clinic. It's a trade-off. You know how we used to give packages from food parcels and stuff from social workers? They lost all of that. So for me, I think it is so important when we think about UHC or NHI and we think about what is it that we are trying to fix. We have to be very explicit. When we say it's an unequal society, we must know what is it that we are trying to fix. This is why, for me, this whole debate is so useless because we tend to focus on this is what the bill says, this is what the act say. But actually, can we just stand back and think about what the spirit of this whole thing is about. And when you stand back and you do that, no one wants to argue with the spirit of what we are trying to do. Nobody. And I can tell you, I've challenged a lot of people on that. It doesn't matter what side they're on, because no one is going to stand confidently in front of others and argue for injustice. Even though in the boardroom they may, because they stand to benefit, but in public they wouldn't. So it is the idea that we need to think about the spirit of what we are trying to do and hold on to that. This is the compass that guides us. This is the thing that guides us, even when we are having difficulties, when we're having debates, because they will come at us with the letter of the agreement. You said this and you didn't say this. What is this? All these legal challenges are about the letter of the act. Yes, we're going to have to sort out the letter, but in all of those debates, let's think about, first and foremost, the spirit of what we are trying to do. And the reason I'm saying to you that the problem is not just about the NHI. The NHI is almost a representation of an underlying problem. And this is what we don't often talk about. And I see it because even when I'm in the university, I see the underlying problem. If I'm somewhere else, I see the underlying problem. I don't think that as South Africans, we have found a way of advancing, in practical terms, social justice in this country. In practical terms, it remains an aspiration. Because when you do, some people are going to have to give up things that are nice. And that's not easy. And I'm talking about giving up power, giving up privileges, giving up money, giving up control, giving up a lot of things. And that's not nice. So social justice then remains an aspiration. And we have to sort out the mess in our value system. Do we really want social justice or not? Please, don't come and be bragging about Ubuntu and this, Ubuntu that, if you don't mean it. If all you're doing is grandstanding and virtue signaling and whatever, that's even more irritating. So if we are serious about Ubuntu, if we are serious about social justice, let it show. For me, I think that it's going to take us a few generations to do this, and what we need is a new crop of leaders who are willing to take this battle on. Nick Crisp is 65. He's going to hand over the baton. So are you ready to take that baton is the question. That's really the issue. The next crop of leaders, they are the ones who are going to have to pick up from where we are to make Ubuntu a reality. And I can tell you, it's not going to be easy. So we can talk about challenges and needs, unequal opportunities, but at our core, in our value system, how committed are we? How committed are we? I'm not trying to turn you into activists. That's up to you. But I'm talking about the relevance of the work that we do, the impact of the work that we do, the accountability for the resources that you receive to do the work that you do. The public funds that we spend. Can we make it meaningful to society? Can we make it meaningful, the responsibility that the state entrusts in us to impact society? And when I say state, I don't mean government. I mean state. This is important. I know you have issues with government and behavior of certain government officials. That needs to be addressed. But don't confuse government and state. We have an accountability to the public, to the nation, to the people of South Africa. We are the brain trust of the nation, and we've got to make sure that when it comes to these issues, we find effective solutions, which is why I started off by saying that you are the ones who can answer the many research questions and the many unknowns that we have. I'm going to wind down by saying to you that what we are trying to solve, it's a divide between the public and the private sector in terms of healthcare that has been created over many years, which in many ways, it's got its own pros and cons. It was painful for me to find out that 30 years ago or so, the public sector was much stronger than the private sector. Best surgeries were done in the public sector. Best specialists were in the public sector. But things changed. And now the private sector is able to recruit anyone by dangling a carrot. And it became a perfect storm. You take away the best doctors into the private sector, the quality of the services start to deteriorate. You start to have medical legal claims. You pay that. You don't have funds for infrastructure and maintenance. It's just a perfect storm. The system just deteriorates and deteriorates and deteriorates. And I'm hoping that we are at a turning point, Nick, that we can curb that, because we cannot afford to continue to bleed the way that we are. And I know many people don't quite see it the way that those who have watched the trajectory of the system over time have watched it. And yes, there's been people who have been irresponsible in the decisions from the government side. But when you stand back and look at it, the private sector is not innocent. But they will not admit to that, because they will tell you that it's your responsibility to try and retain your people. I've been involved with Quest, Quality Evidence for Health System Transformation. At the core of it, the high quality health system requires that we deal with the needs of the population, consistently meet the services and achieve the health outcomes. But most importantly, there needs to be trust. Can we do that? Can we build a health system that is trusted by the people? And can we measure it? We recently introduced the People's Voice survey in an effort to try and understand if we can measure these things that are difficult to measure. And we did it in both private and public. And that's the thing, it should become easy to do research in the private sector. It should become easy to do research in the private sector so that we can have the data. If they refuse us, we should take them to court. So I'm hoping that as we have this conversation today and tomorrow, we really think about how we can build trust and measure trust. Let's talk about trust. If a health system is trusted, it will deliver. If we endeavor to be trusted, to be worthy of trust, we will see a high quality health system. Let me take this opportunity once again to thank you for inviting me to share my thoughts and wish you all the best. I know, unfortunately, I won't be able to stay throughout the discussions, but I hope that helps to set the tone for the discussion, and I'm looking forward to further discussions and the outcome of these discussions. Thank you very much.
Okay, so we have lots of time for discussion and questions. So while I'm walking over there, if you can reflect on what you've heard, and we have roving mics, so please put your hand up for either a comment or a question. I can walk very slowly. Are you on microphone? Could you, just for me, introduce yourself and tell us where you're from?
Sure. Hi, I'm Sue Goldstein from Priceless Fits. Prof, thank you so much for your talk, and both you and Tobeko emphasizing health promotion and the upstream issues. And the question is not really for you, but it's a challenge to Nicholas. How are we going to deal with this in terms of the NHI? I just love the way that your emphasis of the talk, so that's much appreciated. But in my understanding at the moment, there is no actual body that is dealing with health promotion. There's no funding for health promotion, and it's not even discussed either in the National Health Compact that was just signed, nor in the NHI bill. Thank you.
Protect Nick. Yeah, I think that one of the things I was also saying yesterday, and I see it again in many places, the fact that we keep using the old tools for new problems. Our structures are archaic, and we don't adapt very easily. And the reason I'm saying that is that I think what would really be helpful is to think about, to take the time to think about what is it that we would like to see happen in order to achieve better structures and services for health promotion. That's really, for me, the question. I've been thinking about this a lot as well. You know, so part of the problem is that whenever I try and think about what the Department of Health needs to do, I think they run the risk of compromising current services if they engage in a drastic shift towards something. We know that effective health promotion will reduce burden from just epidemiologically. If you reduce what comes in, then you will have reduced costs and burden on the services. Health promotion can help to do that. But I suspect that we probably have to set up a whole different system to do that, find ways of funding it, you know. And I don't know that the way our Department of Health currently, the way it's structured, it can actually change its mandate. I think they need to support the efforts to build a more effective health promotion. I also think health promotion has to be coordinated between different departments. It's not a function only of the Department of Health. It has to be coordinated across different departments. We need a different structure. And I think that's why I'm saying, you know, Nick can defend and justify, but at the end of the day, they have to keep running what they're running now in order to hold things together. I just think that perhaps what we need to be campaigning for is a different way of doing things. And it's not the Minister of Health alone. It's really going to be the presidency, in my view, that needs to be on board to support something like that.
Hi, Prof. Thank you for the talk. I was really, I liked what you said about new leadership. And I think what I want to ask is, how do you toe the line? So when I was a student, it was, let's burn everything down and start again. How do you toe the line as someone who's an emerging scientist or researcher between this system is very unfair and I don't want to see it anymore, and we have to slowly let things change?
The question you're asking is very important. It's so funny. This is why it's like deja vu. I've been having this conversation about the activism, the radical activism that says, let's burn everything down, right? In a way, you know, I have some degree of appreciation for it because it forces us to stop and actually do something about issues. I can tell you, Nick can tell us that there's no budget for this or that, right? But if we start burning things down, he's going to give us the money, right? But here's the problem. Fees Must Fall, the Fallist movement, it changed the landscape of higher education, for example. Do you know that right now we're dealing with a lot of students or graduates from that time who are having trauma from their experiences back then? They feel bad about things that happened. They can't move on. Some of them could not finish degrees. Some of them are depressed and they're struggling with mental health. We are learning that when students go through that, burning everything down, they don't come out of it unscathed. And the same goes for any youth leadership who takes that radical approach. As long as you're a normal human being, you don't come out of it unscathed. And that also determines the kind of leader that you become. So we don't want that. We don't want our young people to be traumatized by their aspiration and interest in leadership. We want it to be constructive. But also, we want to make sure that when you come to us and say, Prof, this is the issue, 1, 2, 3, I can listen, I can hear you, and I can respond. The problem is that when I go to Nick and say 1, 2, 3, he doesn't listen. He's going to say, I've got too many other problems. And that's why a new crop of leaders needs to be able to do things differently.
I'm learning that actually sometimes it's not even about you doing something about it. Nick, it's not about you fixing it. It's about you learning, understanding, and somehow accommodating the best way you can under the circumstances. It goes a long way in shaping the outcome in the future. So I only feel bad for young people who have to fight so hard, not just in universities, but in society as a whole. I was looking at the demographic trajectory of the number of young people that are going to become 19. 2020, 2021, it was the lowest that it has been in a long time because it was sort of momentum of the people, the deaths from HIV/AIDS, a lot of deaths there. So we had a dip. So we are only going to start peaking in 2026, 27, people who are 19. That tells you we've got a whole new cohort that's coming of young people in the next 2-3 years who are not going to be able to get into university, who are not going to be able to get jobs and all of that, and it's going to exacerbate the social instability that we have in this country. And that number will remain like that up until 2038. So we have a problem in our hands that's coming of youth. And that's why I feel like if we want to protect our youth going forward from the trauma that they experience having to fight for their rights, we've got to have a different kind of engagement, a different kind of leadership. And it's not just on the side of the youth, it's also on the side of the leaders. So the leaders the next generation of leaders really need to learn how to engage differently and not be paternalistic or whatever, but also find creative ways of accommodating the needs of these young people. I'm worried about the next 10, 20 years until we see the stability, because our economy is not really going to improve in the next short term, in the next medium to short term to medium term. So I hear you, but I think that is another thing we can do. We can figure out how we prepare our leaders, how we position our leaders to kind of tackle these complex issues, and how we prepare the youth to engage with a new generation of leaders. And again, how we incorporate the value system. Our next generation of leaders have to be a lot more humane. A humanist approach is going to be so important in the next, at least next 10, 20 years. Otherwise, we are not going to be able to cater for the true challenges that exist, but also the sort of emotional and mental struggles that our population is going to have because we can't cater for their needs.
Okay. Hi, I'm Jean-Marie Tucker. Lots of people know me as JM. And I wanted to say thank you for an amazing opening presentation. I loved how you brought together the issues of trust, social justice, knowledge translation, and the accusation that you're a professor of semantics. I'm doing my PhD at UCT, and I'm lucky enough to have Helen Schneider as one of my supervisors as well. And one of the pieces of work I'm looking at is the definition of the benefits package. And I think when in a lot of the discussions that we have, a lot of people talk about trust and being willing to potentially give up services that they would no longer have if they know that more services are available to the more vulnerable. And I think it's just one example of where being clear, defining things explicitly, and then making sure it's translated into information that people can understand is very important. So that was one comment I wanted to make. The other was, I thought, just to kind of get people thinking, was that I think in terms of health promotion, I think we need to remember that within the context of NHI, the NHI fund is funding personal healthcare services, whereas promotion and health promotion, my understanding is that that is still falling within the National Department of Health. So I think there's a lot of room for understanding in the context of defining benefit packages from a treatment and a prevention and promotion perspective. How do we support the health sector to align those across those different stewards at a national level of South Africa? So I'd be interested to hear your thoughts, not to put you on the spot or anything.
So he's telling me not to go to town in my response. I get too excited. I think Nick is going to comment on benefit package, trust me. He doesn't miss the opportunity to do that and the injustices around that. But I think on the health promotion, you know, in the NHI Act, there is this thing of contracting primary units. It's one of the things that we don't talk about. For me, it is one of the most powerful things in the NHI Act. And I'd like you guys to talk about it. You know, I think Nick is happy. It's not a good thing when Nick is happy. I think one of the things we have to think about is most people that kind of shape the health system are often clinical people. Clinical. And that's why we often shape the health system to be individualistic, and we shape the health system to be reactive in terms of services. We've got to be a little bit more disruptive. We know that the strength of the public health system is primary health care, but primary health care, when we talk about it, we talk about primary health care clinic, but I'm talking about primary health care comprehensively. So that starts in the household. And I trained in demography and health, and I am interested in a population approach when you're thinking of health promotion. That's why it's also multi-sectoral. But these are too complex. These are not things that, you know, we like to work with. It's just easier for me to have my stethoscope and listen to the heart sounds or the crackles in the chest. You know, the rest someone else can worry about. But we need people who are willing to grapple with that, with the complexities of having to deal with the population approach. We say this. You want to have a hospital, its surrounding clinics, and the household or so-called catchment population. You want to have the ecosystem as a whole. And in that ecosystem, you also want to make sure that you know everyone who lives there. You deal with all their risk factors. And that's why you guys have to engage demographers. This is what they've been doing for a long time. That's why I ended up working with Agincourt. And I ended up working with Hlabisa. Because what I realized was that we're sitting in the clinic, focusing on clinical epidemiology, waiting for people to get sick, come to us, and then you'll be sitting in the HIV clinic, seeing these people with very low CD4 count, and then the next month they don't show up. You've got no idea where they are. But people have developed, you know, systems to track everybody in the population in this country. They know where they are at a particular point in time, and they know where they live. They've got GPS coordinates. So how serious are we about making sure that we're promoting health and well-being? And it is simple. You bring together clinical, I know, right? I'm still going on. You bring together clinical epidemiology together with demography. You've got like household clinic link. Kobas and them have been working for years to try and crack this, and they have. So how are we not using these innovations? That's why I really think that let's think about how to look after a population of people and making sure that they are well from the time they are born, and exactly as Ndobeko said, life course approach, but also well-being in the household and drawing on different sectors, not just the kind of health that we understand, but broadly sanitation and other things that we need to bring in there.
You have the last question. I tried hard to make sure you had some space. I apologize, but we have time for one more question.
Yes. Thank you, Prof. Moshabela. I want to just first say what a compelling presentation and how refreshing for me in the health space to have an intellectual who's honest and who is in touch with his feelings, how he feels about things. The late Black feminist and philosopher Audre Lorde pointed out how systems of oppression have worked to ensure that we produce superficial solutions to problems and generate superficial knowledge by requiring us to fragment ourselves so that the feeling and the thinking are separate. Requiring us to think, not feel. And your presentation is a perfect illumination of that importance, that when you connect the thinking to the feeling, you're able to get us to the heart of the matter. And you're saying to us, the heart of the matter is, what are our values? If we're saying we want a health system that's grounded on the philosophies of Ubuntu, we first have to ask, who gets to be who gets to be human? Which is what is exposed by many of the interventions and the solutions in this country. If you look at housing, you get to see who gets to be who is a person, who qualifies as a human. The fact that our solution to inadequate housing was to, well, we'll build them small 30 square meter RDP houses in the very ghettos that we have agreed are not livable spaces. They were not built for human lives to thrive. But we are going to keep them intact. We're going to maintain special apartheid geography. We won't mess with that. We're just going to put houses where there were shacks. We see it in our social security system. My twin sister Wanga, who's an expert on that. The minimalist approaches, because at the heart of it, we haven't clarified what our values are. Who gets to be who gets to be human? Who counts as a human being in this country? How equal is our equal? And I find it so incredible that you've started us on that note. But spirit, what is the spirit of this? Because it gets us, it drives me as an academic. But it needs to start with feeling. Let me feel that I may think. Let that thinking, the solutions that we develop, the knowledge generation, and that takes me, Ramshaw, please allow me this part, indulge me 1 more minute. That takes me to the need for the transformation of how we do research, how we produce knowledge. I don't want to use the fake because it's becoming so cliched and so overused and it's creating all kinds of irritations, decolonization, but at the heart of it, it's saying we need to transform how we produce knowledge. And we will transform it when we have clarified our values. Social justice is not going to be at the heart of anything that we do as long as we are producing solutions from just thinking like machines. Thank you so much. I'm so inspired, gosh, I'm so glad, and extremely unexpected. You don't find this often in health, public health spaces. So great. Thank you.
If you have a comment that is
Okay, thanks very much. So I'm Nick, in case you don't know who that we're talking about. And I was, my PhD was not supervised by Helen, but she was in my undergraduate class. Okay, thanks very much. So first of all, thanks very much to MRC. I'm on a panel later, so I'm going to just confine it to one or two things that I heard in this session. And my good friend Mosa, thanks very much. We are on our third, we have had three health acts in the history of South Africa, 1919, 1977, 2003, and now we have the National Health Insurance Act. They have what has guided us to the mess that we're in today. There are other pieces of legislation that we have also failed to implement that have guided us to the mess. And it's people like us in this room who have to unmess it. So in some of our living memory, Health Act 63 of 1977 was the previous Health Act. It mentions health promotion twice. Both of them are about promoting family planning. Because that's what it was. It was the National Health of Population Development. I was a regional director back in those days with my good friend Kobus helping me to get things done. Now we have a Health Act 61 of 2003, and it starts off with health promotion. There's a whole lot of stuff there in Section 3 about health promotion. So we don't need to repeat it in the NHI Act. What we need to do is ask ourselves, why didn't we implement it? Why aren't we doing what we're supposed to do? And my last comment is for this input is that the CUPs offer us the solution. So what are we trying to do in the NHI is to change the way we pay for healthcare. Let me say that again. To change the way we pay for healthcare. There's plenty of money. I saw corruption, but no fraud there. There was 24 million reported corruption in 3 years in the public service. In one of those 3 years, there was 28 million fraud in the private sector. Why are we fixated on the public sector? That's what Mosa was talking about as well. We have to look at the whole health system, the whole health system. We have to look at social determinants of health. We have to ask ourselves, what's the role of the minister and the MECs in talking to the transport departments about traffic control, talking to the water affairs department about water and sanitation, talking to environmental about air pollution, talking about everything that impacts our lives and our health. That is not the job of someone else. So that is written in the Health Act. We don't need to repeat it in the NHI Act. What we do need to do is look at why are we failing in the way we're paying for healthcare. Because we've created these two completely different ways of paying for healthcare for public sector and private sector. And the CUPs in primary healthcare offers us an opportunity to bring all of this together. And when we sit down with Tamara and yourself and others and talk about how are we going to pay for this differently, what's in there? In principle, what it is there's a combined benefits package, if you like, that we need to describe, and you need to help us do this, that includes promotion, prevention, through rehab, through helping people to die with dignity in their homes, in their communities. And how do we do it? By using capitation, and that's what Mosa was referring to. How do we pay? How do we allocate money to a designated community and say, this is what we need to spend on that community? And we need to get all the providers in that space, optometrists, speech and hearing, community health workers, doctors, nurses, everybody. How do we get them to work together? Not to treat disease, but to get a healthier outcome for the population. That's the challenge for us. It's all already in the legislation and has been for years. So I'm going to throw down the gauntlet to all of us who are here and say, there's our challenge as practitioners. And yes, I'm 65, so I'm looking for a successor. You can bring me your CVs at tea time. Thank you.
Yeah, so I will close by saying that is Nick. You've met Nick. You know, now you see why I pick on him. Yeah, I was writing down your point about let me feel that I may think. I like it. Because at the end of the day, we live once. And what we are going to do with our time and our lives, it has to count. We don't have time to waste. You know, I know science is objective. I'm glad the president is not here. You know, we were discussing this thing of how philosophy itself is shifting from being just about thinking to now being narrative philosophy that includes autoethnography and other things about feeling. But it's the elevation that you're talking about. And I'm very grateful for the invitation and the opportunity to engage. I wish you fruitful discussions. Thanks, Program Director.